everyone, Assalamu alaikum. My name is Momo, and today I'll be talking about uh, reproductive pharmacology as a review. And uh, so the main way I study pharma is mainly through tables, and so don't get overwhelmed if you see that a lot in this lecture. I'll try to make it easier and only highlight on the important points, and these tables are for you to like make it easier and for you to be able to study. So yeah, I hope that it helps, and you can text me or email me anytime if you have any questions, and I wish you all the best. So let's start because there's a lot to cover. So we'll first start with your first lecture, which is infertility and hormone replacement therapy. So to classify infertility, as we know, our there are a lot of hormones from your endocrine lectures. You should know that there's a lot of hormones into play, and something called the hypothalamus pituitary ovarian axis, which helps a woman to become fertile and pregnant, right? So so first let's start with the hypothalamus. It's the main center in our brain that has to secrete gonadotropin releasing hormone, which will then go to the anterior pituitary gland to release the gonadotropic hormones like FSH and LH, follicle stimulating hormone and luteinizing hormone. These will then go to the ovary, which is the target organ, with released hormones like estrogen and progesterone. And these hormones are the main hormones that will help with fertilization, implantation, ovulation, everything to help us with fertility, right? So if there is a problem in any of this axis, a woman will not be able to get pregnant and it will cause infertility. So how do we classify this is the first thing that we need to know. Um, so let's say that the problem is in the hypothalamus or anything related that suppresses gonadotropin releasing hormone. We will call this, according to the WHO, World Health Organization, class 1. Okay? So class 1, or something that suppresses gonadotropin releasing hormone from your previous lectures, should be hyperprolactinemia. Too much secretion of prolactin from the anterior pituitary is actually going to cause um uh yeah, so it's actually going to cause suppression of the hypothalamus, right? And the hormones in general. So that is class 1. And this is a separate on its own. What about class 2? Class 2 is not specific to pituitary. It's just that anything wrong with the system or anything wrong with the signaling. So that's why we call this functional signals, as we will know later. The most common cause for this dysfunctional signal is PCOS, which is polycystic ovarian syndrome. And that has it's basically a condition where the ovaries are full of cysts and they're not able to, so everything, the HPO axis is not the issue. It's because of the cyst that is causing all this um, like derangement and the and dysregulation in the signaling. So the FSH LH will be a bit off and it will not function like pulsatile in a pulsatile manner as it should, right? If you remember. Class 3 of infertility is when the ovaries are affected. So things like such as someone who is having premature ovarian failure. It can be due to a number of reasons. It can be genetic, it can be due to radiation that kind of stop the ovaries from working. Things like Turner syndrome, which has fibrosis in the ovary, like it's not being able to release the egg in time, for example. So anything that causes damage to the ovaries, if there's absent ovaries, this is class 3 infertility. Okay, now this is important to know because again, this is emphasized here. This is from the lecture itself. I noticed that Dr. Hatouf changed a lot from her lectures, and it's very inclusive in a way that it's very helpful to put it here. So I'll just try to make it easier for you to memorize. So class 1, we said everything is low because the hypothalamus is affected. So hypogonadotropic hypogonadism. So low, low, low hormones. Let's start with that. The hypothalamus fails to secrete gonadotropin releasing hormone, and then all of this happens and no fertilization, no ovulation, right? What are the common causes? It can be functional, so someone who exercises a lot, for example, lost a lot of weight, it affects their hypothalamus in that it just suppresses the gonadotropin releasing hormone, and it doesn't allow, and it causes things like amenorrhea, which is absence of a menstrual cycle, and so on. Because of that overall stress on the body, it's not going to release enough amount of that. There are things like, if you remember, Kalman syndrome from the previous lectures, and hypothalamic lesions, so lesions or tumors that suppress the or compress on the brain, right? So, what is the treatment behind this? Is simply you replace the gonadotropin releasing hormone. You can give it in a pulsatile manner, like how the brain was supposed to release, right? So this is the treatment is very simple. It's to replace this gonadotropin releasing hormone to be able to um, increase the other hormones, because the main problem is not in the axis, it's in the deficiency in this hormone. What about class 2? Class 2 is again, PCOS is the most common one. It will cause like a difference, so an increase in LH, which is not normal, and everything else will be near normal, but it's not going to release the egg because the ovaries are having a lot of cysts. You might ask, why is this not an ovary problem? But again, it's because the ovaries are there, the eggs are all, everything is there. It's just that there's a lot of cysts, and it's causing a lot of dysregulation in the signal itself and causing LH to increase. There's androgen increase. It's a whole different syndrome. So testosterone will increase. So there's a lot of things that come into play, which is why we will call this class 2 a separate class on its own. And yeah, the follicles are there, but they just never reach maturity. What is the treatment behind this? So, treatment is to restore normal levels of all these hormones. There is a special like drugs for this, specifically for PCOS, which is letrozole and clomiphene citrate. Okay, just remember these two. First line is always letrozole. Letrozole is an aromatase inhibitor, which means, so aromatase is something, so it's an enzyme that converts substances or inactive form of estrogen into estrogen, right? So if we, for example, inhibit this, it's going to restore the cycle, and FSH and LH can function normally, right? So letrozole will help with this PCOS or class 2. Clomiphene citrate is another kind of drug, which is second line, and its function is that it mainly works on estrogen receptors. So I will come more into that in detail. If these two don't work, you can give recombinant FSH. So you can just start giving FSH in a normal manner as injections, and it will restore that cycle. So the reason why we focus more on restoring the cycle and this hormone is because, again, because the follicles are not or there's a lot of cysts and LH and androgens are high, they are kind of affecting FSH and so on. They can also, yeah, it can not, it's not always normal. It's just that how, like that was on the slide. It can appear normal, but it's not. Okay. So class 3, we said, is hypergonadotropic hypogonadism. What that means is the ovaries are not working, so the estrogen is low. However, so you lose that negative feedback, and FSH and LH will keep releasing it because they're not aware that the ovaries are not being able to produce estrogen, right? So FSH and LH will be high, and it will keep on demanding our body to release estrogen. So common causes, again, ovarian insufficiency, someone having no follicles left, no eggs left, Turner syndrome with the fibrosis, a lot of other syndromes. You don't need to memorize in detail. It's a pharma lecture, so no worries. Um, and menopause, right? So menopause will, it means the ovary reserve is gone, and FSH and LH will be high. So the treatment for this, if someone is not having functional ovaries at all, like no eggs, there is nothing to do kind of to reverse that, right? So the only option for fertility is to do oocyte donation or things like IVF. So you, or surrogate, for example. So you take eggs and sperm and kind of do it outside the body if there is any reserve left. So, like, not the natural way of getting pregnant, right? And then the other thing for these patients are to do hormone replacement therapy. That is important because you want to also have the helpful effects of estrogen. So bone, so for example, like you don't want the person to be at risk of bone loss or osteoporosis, right? So you want to give them hormone to replace that low estrogen. That's the main idea. So, what was the last thing? Yeah, we said hyperprolactinemia is a class on its own, which means prolactin is high and everything else is low. Why? Because prolactin suppresses gonadotropin releasing hormone and it does not give it in a pulse-like manner. It is sometimes grouped with like class 1, but again, it's not a class 1, it's a bit different. So prolactinoma, anything that causes prolactinoma like hypothyroidism will cause this cause of infertility. The treatment for this is the same way you would treat hyperprolactinemia in your previous lecture, cabergoline and bromocriptine, which are dopamine agonists, which will sort of inhibit prolactin, if you remember. That is the natural way of how dopamine works. So dopamine agonists will fix this issue. Now, this is a summary. So, yeah, who class 1 is low FSH LH, class 2 is PCOS, class 3 is ovarian failure, and then hyperprolactinemia is a cause on its own. Now, female infertility, the types of treatment is to, again, restore ovulation. However, the classes will come to it in that a bit. Um, Try to augment ovulation. Um, like in PCOS and to help the body kind of restore the signals. And then there are also other things like IVF and intracytoplasmic, I think, or yeah, this is insemination and other methods such as IVF. So the steps to diagnose infertility is you confirm first an ovulation, which is done by day 21 serum progesterone, which is normally high in our menstrual cycle. If it's low, that means it is not, there is no ovulation happening. Measure the hormone levels, measure prolactin, TSH, exclude other causes of infertility like anatomical. So, and also male factor is important. So, kind of exclude all those. You can also assess AMH, which is anti-Mullerian hormone. It shows the number of ovarian reserves in a female. So, doing that test will help with even the dosing of the pharma drugs. Okay, so treatment. This is the most important slide for the pharma, as for the pharma lecture. So, who class 1? We said we want to treat the problem. So we give pulsatile GnRH. Then second line is you can give FSH and LH directly if that doesn't work. So the anterior pituitary hormones and or HMG. So HMG is it's like a synthetic form of combined FSH and LH. So you are giving both of this together in one medication, HMG. And then or HCG, which kind of if you know HCG is it has a structure that is similar to LH. So that's why we can use that to restore these the gonadotropin releasing hormone or the FSH and LH. Okay. Who class 2 is again PCOS. Remember that. I'll keep repeating. The first line for this is letrozole, if you remember. Second line, clomiphene citrate. Both of these are given in the first day 3 to day 7 of menstrual cycle. Why is that? Is because you want to make sure you are following the menstrual cycle. If you know the FSH and LH should be high during that for those first few days, and it will take some time, right? So you want to give it that window to kind of increase all these hormones and make sure that the ovulation happens on day 14. Third line for this, if these two don't work, we mentioned it, is the recombinant FSH only. Um, Metformin is an adjunct that can be used in PCOS. So especially because PCOS patients, they will have obesity, like high BMI. They will have so again, increased testosterone, uh, increased risk of diabetes. So you want to give them metformin to kind of adjust for this metabolic issue as well. Okay. Who class 3, where the ovaries are failing, you cannot do anything. You can do either IVF or and give hormone replacement therapy to make sure that they are at least benefiting from the good effects of estrogen. Hyperprolactinemia, sorry about this. So you give dopamine agonists. Okay, no need to memorize the doses at all. So let's talk more about PCOS and class 2. Letrozole is first line. We said it's an aromatase inhibitor. It decreases estrogen because it inhibits that aromatase enzyme, which is in other words CYP19. You don't need to know that. It removes the negative feedback, if you remember. So it decreases estrogen, but it restores that pulsatile FSH. Okay, so uh, again, yeah, this is the dual mechanism of how this works. Um, Ovarian, yeah, also enhances FSH receptor sensitivity. Yeah. And again, so I know it's already low, the estrogen was already low in PCOS, but just remember that suppressing it even more will restore that access. Now, what about clomiphene citrate? It's an estrogen agonist and antagonist at times, but for the importance of this lecture, it is an antagonist at the hypothalamus. It prevents negative feed. So it kind of blocks the hypothalamus receptors, right? And then it increases. So wait, I'm trying to. Uh, so it okay. So it inhibits the receptors found in the hypothalamus, right? The receptors that are usually sensitive to estrogen and the progesterone. So if it blocks that, then they are not getting that abnormal signals from the ovaries, right? And the hypothalamus can now function on its own without that kind of dysregulated signal. It's mainly being confused with the low estrogen, high androgen, and so on. So if you block those signals in the brain, then the brain or hypothalamus can function normally and can release GnRH, FSH, and LH in a normal manner. So that is the function of clomiphene citrate. This sounds good, right? But it's still second line. We prefer letrozole. Several reasons for that. It has a short half-life, just no shorter half-life than this. So 45 hours. That means that if the woman is to become pregnant, right, we are giving both of these in day 3, around day 2, 3, 4, 5, around those days. We are giving these two medication so that ovulation can happen at day 14. And then if the person or the woman becomes pregnant, then you want these meds to be cleared before the implantation happens. So let's say ideally, if ovulation happens around 14, pregnancy can occur somewhere around that window, right? So if um if we give letrozole during the first few days, it will be cleared by from the body by the time the woman is pregnant. Does that make sense? Um, Clomiphene citrate has a longer half-life, which means 5 to 7 days. It will likely be there if the woman does have an ovulation and fertilization. At the time of implantation, this medication will still be there. Why we don't want that is because it causes not side effects, yeah, you can consider this as side effects. So clomiphene citrate can cause thinning of the endometrium, and like it will cause the cervical mucus to be hostile, meaning it will be thick. So it will kind of stop implantation from happening, and that's why there's less chances of being pregnant. So live birth is actually less in clomiphene citrate. In studies, they found that letrozole had more live birth rate and ovulation rate, and they're similar, but live birth rate is the most important. It's more because it does not have the effects that clomiphene citrate has on the endometrium. So it is spared, and because so there is no thinning of the endometrium, no cervical mucus thickening, because it is being cleared by the time implantation happens. So it's not there in the body anymore to make these sort of effects, right? Okay. Now, one important side effect of, again, clomiphene citrate, which is why we prefer letrozole, is because it can cause things like hot flushes, headache, mood changes can happen with letrozole as well. But visual disturbances can happen with clomiphene citrate, which is the eye here. So you have to stop the drug if that happens. There's also something called too much of ovarian stimulation, that is called ovarian hyperstimulation syndrome, that are more likely to happen with clomiphene citrate. Remember the shorter name, letrozole, aromatase. So ozole is anything with ozole is aromatase inhibitor. Okay, just remember that from now. This will kind of how do I say it? So the shorter name is more like the one we prefer. So let's just remember that as first line for class 2. Now, if first line, so this is the caution that I'll talk about in a bit, but if first line fails, remember what we said, try to remember it's the recombinants. So we give FSH plus LH together. So FSH plus LH, recombinant means like synthetic. So they're or taken from other like sources. You don't need to know the sources, you don't need to know the uses specifically, just know that it's used in the class 2, sometimes in class 1 as well. So again, if you don't have recombinant FSH-LH, you can give HMG, which are another name is menotropins. It's combination of FSH and LH together in one drug. So you can just use that. Or HCG, which mimics LH and can trigger the LH surge and make the follicles, again, make the whole ovulation and the axis work. Um, the route for all this is either subcutaneous or IM, because if you ingest orally, it's going to be destroyed and it's not going to have. So hormones in general, you have to have it in the blood to work, right? You no need to know the starting dose. Just keep monitoring the patient for like ultrasound, repeat like estradiol levels, which is estrogen levels, to prevent this condition. So this condition we said is ovarian hyperstimulation syndrome. It can be caused by parenteral treatment, which is like we said IV, or yeah, so with IV mainly. So with huge like if someone is given IV treatment, they are more at risk of the syndrome. Again, also clomiphene citrate can have an effect as well. So what is it exactly? So it's kind of overcorrection. So let's say you give someone estrogen or all these hormones, it instead of restoring the balance, it tips the balance over. So it overstimulates the ovaries, I guess, and it causes even more damage than what you intended. So why is that? That's because from the hyperstimulated ovaries, you get something called vasoendothelial growth factor release, which is it's a growth factor for blood vessels. So they cause vascular permeability and fluid to kind of go out, causing ascites, and edema all over the body. So you don't want too much estrogen. So remember how in the menstrual cycle, too much of estrogen, even regularly, it can cause bloating in females, like they don't feel good. Imagine it being 100 times worse because they're overstimulated and you just get bloating everywhere with the edema. So I hope that made it easier. So the prevention for this is, so let's say this does happen, you kind of reverse what you were doing before fixing the infertility. You have to treat this first. So be cautious with HMG as well, because this can also cause that. Now, GnRH antagonists can be given. So you kind of again antagonize what you kind of try to stimulate. You can give GnRH agonist trigger. So sometimes giving continuous GnRH, not in pulse-like fashion, can also stop the ovulation from happening, stop the hyper. Again, it will only work if it's in pulses. So if you just, if even if you give agonist continuous or antagonist, they will both work to stop this hyperstimulation. Cabergoline, remember that's a dopamine agonist, but in this case, it will phosphorylate the VEGF, the growth factor, and it will reduce the permeability, reducing edema. So you're fixing the problem here. The other thing is you can freeze all embryo surgery. It's not that important. I've not seen it a lot, but yeah, it's yeah, I'm not sure what it is, but I guess it's to treat the infertility. If this does happen, you can kind of keep the embryo, like use the freeze embryo, and then use that later on. Now, since you have a lot of overstimulated ovaries anyway, there's likely more eggs being matured, right? So, what are the symptoms of OHSS? They can be bloating, remember, pain, that's in mild, like nausea, vomiting, everything that happens during our, like during the menstrual cycle, during like someone who has PMS, for example. If it's severe, it can cause ascites, which is like severe distension of the abdomen, oligorenal failure, and thromboembolic risk. The management is to hydrate them, give them pain medication, stop these drugs, and try to prevent or give antagonists for to kind of restore, to lessen the stimulation. Again, same thing, IV, you don't need to know this, but severe, you can hospitalize the patient. Okay, I hope that was clear. That is for infertility. Be cautious of OHSS, which of the following is a side effect of that? So I'll go on because this is a recording. It is all of the above. So thromboembolism with increased estrogen. If anything you remember from this lecture, just know that estrogen has a high risk of um, causing embolism or thrombotic events. So that is always the case. If it's hyperstimulated, obviously it will increase that risk. Shortness of breath, remember, it because of the ascites, because of the edema and the bloating, it can cause respiratory distress as well. A 27-year-old woman who was having trouble started clomiphene. Okay, so 8 weeks later, she had positive pregnancy test. Which of the following is the site of action of clomiphene citrate? So where does clomiphene work again? Remember, it works in the hypothalamus. So hypothalamus, the receptors, because of that signals, you want to block the receptors so that the hypothalamus can work. They should have been started on letrozole, but this is just how the question is. What class of infertility is this? If they are being started on clomiphene, the person is obese, has a lot of acne, hirsutism, not regular periods. This is class, oh, sorry, I didn't write it, it's in the notes, class 2 or PCOS. Okay? Which of the following is considered as the most appropriate time to give clomiphene citrate? So it should be in the first few days of the menstrual cycle, which is day 2. You might see day 3, 4, 5. That is correct also. Why is letrozole chosen over clomiphene citrate? If you read over the options, it is all of the above. So it has milder adverse effects, no visual disturbance, for example, less likely for OHSS, and it does not cause the thinning. It has greater live birth rate. All of this is related together. So that's because what is the main reason? I hope you remember from the table. It has a short half-life. It is cleared by the time implantation happens. How does letrozole work? Which is the other question. It inhibits aromatase. Okay? Aromatase inhibitor. No, so nothing like it does not affect receptors. This is for the clomiphene citrate. A is for clomiphene citrate. Let's go to hormone replacement therapy. So, hormone replacement therapy, again, remember, if someone is deficient in estrogen, estrogen is still a protective factor for all of us, right? So we want to replace that in certain cases, like menopause here, if you see, or premature ovarian insufficiency. Now, for people with menopause, you have to, this is important in your lecture as well, you have to offer to symptomatic women less than 60 years old or within 10 years of menopause after discussion. So you have to always bring this topic up. They might not know, they might be in menopause and suffering from symptoms, and you always have to offer this as a treatment for them. What I mean, so that is the discussion and the offer part. Symptomatic means the symptoms of menopause. So let's say someone, so before that, let me define menopause. Menopause is not having periods for at least 12 months. And that happens an average of like 51 years old of age, just because the ovarian reserve is diminished. Okay, and that's a natural thing. So symptomatic, this is a mnemonic for you guys. Menopause can cause havocs. I still use this mnemonic to this day. So hot flashes is one symptom. So they always constantly feel hot and they cannot help it, but that is part of menopause because of the deficient estrogen, high FSH, high temperatures, right? Havocs, atrophy of the vagina, because estrogen, progesterone are not there anymore, to kind of be helpful for that. Osteoporosis is so bone loss is a very important thing. Coronary artery disease can happen because the blood vessels become less elastic and they become much harder because of the lack of estrogen. And sleep disturbances, so havocs. Okay, this is again same thing that is here. This is from the lecture. What is the most common cause or symptom that they will complain of? It are something called vasomotor symptoms, which is the first thing here. Hot flashes, night sweat, or hot flashes, night sweats, palpitation. Atrophy, low mood, depression, it can cause a lot of things, which is things to do with sleep as well. Skeletal is the O, bone, and cardiovascular is coronary artery disease. You don't need to know again what inhibits what, but just know that estrogen was helpful in yeah, so estrogen was helpful in bone growth, but having that less will cause bone loss. Okay. Now, it can be also used. Okay, these are the symptoms. So, symptomatic women less than 60. Why is that? Because less than 60 is still, they are less at risk of atherosclerosis, because while they're not as like hard as older age, they are less at risk of thromboembolic diseases. So anything less than 60 is healthier. That's why. Within 10 years of menopause, so let's say someone had menopause like earlier than normal, so 48 years old. That's still fine. You can still give them within the 10 years. If they are like 57, 58, that's still within 10 years, which is fine. Of menopause after informed discussion, right? We mentioned all this. This is important. Absolute contraindications of so that is all of menopause. You want to give replacement therapy, so you want to give estrogen and progesterone. If the person has, ideally you want to give the normal, right? So you want to give combination of estrogen, progesterone, and that is more protective. What are the contraindications of giving these two hormones? There's a few. So things that will worsen the condition by giving these are things like breast cancer. So you don't want to feed like estrogen and progesterone to someone who is having like hormone like sensitive breast cancer. So active or recent breast cancer, estrogen dependent cancer, any other cancers. Liver failure is an important thing because estrogen and progesterone are metabolized in the liver, so you don't want to worsen that liver disease. Undiagnosed vaginal bleeding, because this is a very it's in a gray area. Vaginal bleeding can be caused by a lot of things. It can be caused by suspected pregnancy or something, and you don't want to give something that you don't know the cause of. So don't give it in someone who has bleeding that is we don't know the cause of. There's untreated endometrial hyperplasia. In other words, which can cause endometrial cancer, right? So you don't, cancer is always a bad thing. Um, Again, someone who is already having venous thromboembolic disease, arterial thrombosis, don't give estrogen, progesterone to kind of worsen that. Thrombophilia disorders, also the same thing. Don't try not to give that. It's absolute contraindication. So hormone replacement therapy can be given in menopause outside of these. It can be given in premature ovarian insufficiency, which is what some people have at the age of 40, less than 40 years of age. They have less or diminished egg reserve. So they have the same symptoms of menopause. It's just way earlier, ahead of of their time, right? Surgical menopause is someone who had surgery removing the ovary uterus, so they will not have naturally the estrogen and progesterone, so you want to give them replacement. So for premature ovarian insufficiency, you just want to give enough. So again, offer HRT until the natural menopause age. So you just want to make up for lost time, if that makes sense. So until they reach the menopause age, which is average 51 years old, you want to replenish that over estrogen progesterone just so they can um, not experience these at a very young age, and you want to keep them until they go naturally into that. So less than 40 years, FSH is high. That is the diagnosis of premature ovarian insufficiency. Causes, again, we mentioned. This is combining with which class? I'll give you a second. So, premature ovarian insufficiency, we talked about it in class 3 of infertility. All these causes are the exact same. So, ovaries are not enough, they are not working. Higher doses, okay, so hormone replacement therapy, if you are giving hormone replacement therapy, you need higher doses um, than usual, than someone who has used HRT, just to be more efficient. And it is combined with progesterone because, again, you want to mimic that natural pattern. Who class? Oh, it's there. Class 3. So how do you fix the fertility in class 3? We said HRT is given. Other than that, you can do IVF and oocyte preservation. So before someone goes chemotherapy, radiotherapy, before they lose the ovary function, you can store like the eggs by oocyte donation as well, and cryopreservation. There can be sometimes spontaneous ovulation, but it's very, very unlikely, right? Because the ovaries are not working. So without hormone replacement therapy in these patients who are less than 40 years old, they did not even reach um, above 60, you can have serious consequences without that. So things like cardiovascular disease risk is higher because you have low estrogen. The vessels will be thicker, and yeah, it will just lead to these symptoms faster. So you don't want that. Osteoporosis, we said dementia, insomnia, depression, sleep, and then premature mortality as well. Menopausal symptoms. I'll fix the spelling mistakes. I don't know what happened, but yeah, menopausal symptoms in infertility, right? What are the types of hormone replacement therapy that we want to give? So estrogen and progesterone. What is the important, uh in a nutshell? Give bioidentical. So give as much as close to the natural estrogen progesterone there is, which is 17 beta estradiol, and microionized progesterone, which is the same, right? Now, we will talk about the types, but patch is good. So patching the estrogen patch here is good, or oral or vaginal supply of progesterone. This is preferred because transdermal, the patch, will avoid going to the liver. So remember how I said it's metabolized by the liver? So if that doesn't happen, there is no increase in thromboembolic risk factor, no increase in stroke, cardiovascular disease. Why? Because it's not in the blood, it's just a patch, right? So it will slowly release estrogen just to your body without going to the liver. Progesterone, again, lower breast cancer risk than synthetic. So that's what I mean. Try to use the natural ones, not the synthetic ones. They had a study that was done on equine like estrogen, and they used something that was very synthetic form of progesterone. That one did not work at all. And that's why that study is called Women Health Institute study. This was, believe it or not, this was a question in one of the past where they asked what was the study. So I'm just mentioning that. So Women Health Institute, they performed a study where they combined these two drugs that were synthetic, like not close to the normal estrogen progesterone, and it caused a lot of bad effects on so thromboembolic risk and everything of that sort, like many side effects. Which is why in 2002 afterward onwards, a lot of women stopped using HRTs, and it caused a decrease in HRT. So right now, with the new research and new encouragement from the physicians, remember, you have to offer, it is being picked up. But that drop was because of one study that used wrong drugs, even the wrong population, by the way. They used someone over the age of 60, which was already like at risk of thromboembolic and cardiovascular, which is why here the age is important, right? And that's how they got it in the, that's how they realized that the study was wrong, because you have to test in patients who are less than 60. Okay, let's go to questions. 52-year-old woman, you can read it and speed this up, but so she got prescribed hormone replacement therapy for her menopausal symptoms. This therapy carries a small risk increase in risk of which of the following? It is, we said, breast cancer, right? So we don't want to give it in breast cancer. We didn't say cancer, endometrial cancer directly. We just said hyperplasia. So breast cancer is more important. Osteoporosis, no, not really, because it kind of protects from osteoporosis, right? 45-year-old woman came complaining of menopausal symptoms, no flushing, hot flash, night sweats, sleep disturbances, and so on. And she's extremely fatigued, irregular menstrual cycle for the past year, maybe menopause, skipping 2, 3 times at a time. Which of the following preparations would be most appropriate for short-term replacement therapy in this woman as HRT? What did we say? We said having combination is good and having natural ones are good. So that is E, which is combination. The rest is like only progesterone or estrogen, so we don't want to give only one. There is one case, just remember this. I should have written it down, but remember this. There is one case where we only use progesterone. That's in patients who have, or sorry, only use estrogen. That's in patients who had a hysterectomy. So hysterectomy is removal of the whole uterus. If you remove that, there is no increase in endometrial hyperplasia, right? So you can give estrogen. That is the main concern because estrogen is the one that causes endometrial hyperplasia. So when we combine it with progesterone, it protects from that effect. But if someone has no uterus in the first place, you can just give estrogen because uh, it will, there's nothing to increase the risk of, right, endometrial hyperplasia. So having the combination mimics the cycle and it protects from endometrial hyperplasia and cancer, which is why we give combination. So these two reasons are the main thing we give combination in the first place. Which of the following conditions is a contraindication? Liver failure. We said this, right? Okay. Let's move on to hormonal contraceptives. This is the one of the last lectures, but I moved it up here because it's very related to what we mentioned in HRT. So I don't want you to get confused, okay? So maybe having them together will help. This is just how my brain works too. So we said hormonal so contraceptive, we are not replacing the hormones anymore for like menopause or things like that. Contraceptives are to stop someone from becoming pregnant, right? So contraceptives can be how do we say this? So so we'll come to it. So contraceptives are again ways in which pregnancy can be avoided. So there's 4 different ways. There's barrier types like condoms, vagina, like sorry, not the hormonal. So condoms. There's other forms of barriers that can happen uh, to prevent that. Intrauterine Devices are one thing, like copper. You can, if you put copper rod inside the uterus, it stops the implantation from happening, so stops pregnancy. Why is that? It's because it will cause a unnatural environment in the uterus, and again, it's a something in the uterus, so it will not cause implantation or pregnancy to happen. It will cause irritation of the walls. Hormonal is what we will talk about. So that's, I'm just trying to get into that. Permanent is by surgeries, so removing the tube, removing sperm duct in males, in females, removing the ovary, fallopian tubes, and so on. Um, See here, the WHI study led to downtrend use. This is in the HRT, okay? I will replace that there. Now we will talk about hormonal. So there are pills, there are different routes in stopping pregnancy. You can affect, for example, at the HPO axis by kind of playing around with the FSH and LH. You can do it at the cervix, for example, with the barrier, with a lot of hormones that can act on the cervix or endometrial and fallopian tubes. So why I highlighted FSH is because FSH has a much stronger play in fertility than LH. So just keep that in mind. Okay, it was one of the questions, so that's why. So hormonal contraceptions or contraceptives are many different types. There can be oral of combined estrogen progesterone. Oh, so I should mention that it is similar to HRT. It's just different dose and routes or routes of giving the medication. So it has estrogen and progesterone, you see here, different types of estrogen and progesterone, various preparations. Again, it depends how you give it. So oral, it you can have combined or you can have progesterone only, estrogen only, but that's not recommended here in the contraception, and postcoital, so emergency contraceptive oral pills. I'll talk more about this. Injectable, which is by injection, so progesterone only or combined. Always it's either progesterone only or combined that can happen. Estrogen only, again, like I said, one scenario, which is hysterectomy, someone who has no risk of endometrial cancer. Injection. Okay, we said transdermal patch, if you remember, it's just a patch on the arm. Subdermal implant, that is an implant, not on the skin, but under the skin. So that is different. Vaginal ring, here, that's here. Oh, so this is the implant, for example. The patch is on the skin. Vaginal ring is a ring that the woman places inside the vagina. It releases a hormone that will stop fertilization from happening or the sperm from going upwards. Interuterine, which is this IUD. So intrauterine device that is hormonal. Levonorgestrel is a type of progesterone, so it's hormonal IUD. This one, interuterine copper, is not hormonal. It's just an irritant, or but it's very effective. So in stopping fertilization, here we are only talking about hormonal. So pill, implant, injection. This is the contraceptive type. Okay. Now we said they can consist of estrogen and progesterone. So let's talk more about that. First, we'll talk about oral pills. Okay, oral. We'll talk about combined because that is one of the most common types of contraception. Oh, I should mention also, these contraceptive pills, they can be used for birth control, or symptoms of having, like, so if you hear someone say birth control, it's not only because they are not trying to get pregnant. A lot of like young girls also take birth control pills to regulate their periods. So heavy periods, painful periods, you want to regulate it, so they take oral contraceptive pills to do that. Okay, or birth control pills. So we said that it has estrogen and progesterone. Sorry for the slides. I'll try to explain as much as possible, like as best as possible. So don't worry. um, okay. So wait, just let me check if I'm not missing something. Uh, let's see for. Okay, yeah. So I just mentioned. I'm just trying to make sure from the notes that I didn't miss anything. So, okay, we mentioned that, we mentioned this, okay. Yeah, so, yeah, symptoms of having heavy periods and so on. Okay, so now let's move to here. So, estrogen and progesterone. Now, estrogen can have different forms. Ethinyl, if you see the word estradiol, esterol, estradiol, something, they are part of estrogen. This is highlighted because this is the one Dr. Hatouf mentioned, and it's good to know. It's the most common one, I guess, in preparations for combined. Estradiol valerate has smaller risk of VT, venous thromboembolism, but it still has that risk, as with all estrogen. Progesterone has different generations, so first gen, second, third, fourth. Why is that? That's because they all have a bit of difference in activity on the androgens. So first generation is, so the ones in red highlighted is the ones she mentioned. So that's what I'm gonna focus on. Don't memorize all the names, it's completely fine. So norethindrone, esterone, trenol, if you hear these names, they are progesterone. Levonorgestrel, norgestim, right? What is the difference? Second generation is more androgenic. Third generation is less androgenic. Just that's more than enough to know. I don't think they will ask which one is which. So I think you're good with that. Fourth generation is a bit important because she keeps mentioning this, so I have a feeling it's important. So drospirenone again is a progesterone, but it's special because it has an anti-mineralocorticoid effect. Anti-mineralocorticoid effect, anti-androgenic effect. So not androgen at all. Why is that? Only for this. So these are part of fourth generation, but anti-mineralocorticoid is only for this. So mineralocorticoids in general in our body, they regulate our blood pressure, our sodium absorption, potassium excretion. If it's anti-mineralocorticoid, it sort of like disturbs that, right? With our hormone. So just remember that for this. Now they can come in different preparations like monophasic, which means constant dose of estrogen progesterone, multiphasic, which means different dose, um, and so on. You don't need to know. Extended means over a long period of time, continuous means over a year, long period of time with the same. So continuous without stopping the pills for not even for 1 day. So that's continuous. Extended is you will still stop it for a few days, which I'll come to in a bit. Again, these estrogen progesterone are always metabolized by the inducers in the liver. So let's say there are other medication that someone is taking, like anti-epileptics, carbamazepine, phenobarbital, which were highlighted in the lecture. So anti-epileptics, antimicrobials like rifampin. Someone has tuberculosis, they are being treated with rifampin, or someone is taking herbal over-the-counter St. John's wort for, let's say, blood pressure or something. All of these affect the inducer, the liver enzyme. So it increases the activity of that liver enzyme that is supposed to break down estrogen. Okay, so let's say that this is induced and someone is taking birth control pills like the oral contraceptive pills, they will be more metabolized faster, like faster metabolism than normal. So because of these drugs that are inducing this enzyme. So this enzyme is being hyperactive and breaking down estrogen left and right, these pills left and right, which means that these pills are being cleared faster from the body. So metabolized means they are being cleared and they're not being used effectively. So that means that the woman will have a higher chance of becoming pregnant because these pills will fail to become a contraceptive. Does that, I hope that made sense. Now, how do we give it? In what dose? Usually we give 28 days total. Um, 21 days you have, so 28 days is our normal menstrual cycle. 20 in women, 21 days they have to take the oral contraceptive pills continuously, and then from the fifth day of menses, then 7 days they don't take any more contraceptive pills. This 7 days is the window period. They will take another pill, but it's a placebo, it doesn't do anything. And when they stop taking it for the 7 days, it will uh make them have the period. So this is called withdrawal bleeding from the placebo. So this regulates the period in people who have heavy menses or painful menses, right? So again, 21 days taking the pill, 7 days placebo, or just taking an iron pill, for example, because they might be deficient in iron, but not the oral contraceptive pills. Just remember that timeline. So this is what this said. Like monophasic is same dose throughout, multiphasic difference, extended is over a long time of the same thing, continuous is without the placebo. So you just take continuously if someone doesn't want their periods, for example. Okay, I hope that made sense. This is 100% effective, and it's very important for someone who's taking a pill, because they have to make sure to take it at these days and not take the 7 days. Now, what are the effects of having excess estrogen, excess progesterone? So, we said already the side effects of having, if you remember, and contraindications, they are mainly the same. So, having too much estrogen can cause breast tenderness even more so than progestin. Think of someone being pregnant, they will have high levels of estrogen and progesterone. So all these symptoms are kind of how a pregnant woman would complain of. So breast tenderness, nausea, vomiting, headaches, migraine, it can be migraine, weight gain, mood swings. If you remember like fatigue, the pregnancy symptoms, that will make sense, right? Because they have too much of estrogen, progesterone. But pregnancy is a normal thing. And you are trying to prevent that. And if you give too high of a dose, it will cause similar symptoms. So estrogen, other symptoms, it suppresses lactation. So it kind of for breastfeeding women, it's not recommended because it will suppress the milk formation. It can cause gallstones because of this being metabolized by the liver. It's being hyperactive, right? And hypertension is a unique feature of estrogen. Remember, hypertension, a thromboembolism can happen. So migraine can also be increased with estrogen, and something in the liver, hepatic adenoma can also be a finding in people who use a lot of estrogen. So adenoma is a benign tumor in the liver. Progesterone is breast tenderness. Again, remember all the symptoms. I'm not going to go over the similar symptoms, but lipid profile can be changed. They can have acne, hirsutism, especially because they are more androgenic, the second generation. So levonorgestrel can have these effects. Amenorrhea can sometimes happen because you are playing with the period, right? So someone can have absent period for a while, and then breakthrough menstrual bleed. This is the most common. It's highlighted why? Because it's the most common cause of someone stopping these pills. They will have periods even if they're taking consecutively. It's just how their body is responding naturally. There can be more sensitive, right? So there's a lot of things. So having irregular period once in a while can make them stop, and it's the most common side effect of progestin that people complain of. Drospirenone, remember this drug? It's the anti-mineral corticoid. So if you are I said mineral corticoid usually excretes. If you are anti-mineral corticoid, it will not be able to excrete potassium. Potassium will build up in our body, causing hyperkalemia. Hyperkalemia is a very, very dangerous risk factor of arrhythmia, so you do not want high potassium levels. It increases the risk, especially if someone is taking ACE inhibitor, ARBs, potassium sparing diuretics, because all of these cause hyperkalemia. So you don't want to layer that on top of each other. So be careful. And I mentioned these drugs as well because you don't want to give, or you want to consider giving oral contraceptive pills in someone who is having seizures, someone with tuberculosis, right? I hope that made sense. Now, there are different categories for we're still on the same one. Combined oral contraceptive pills. I promise the rest will be faster. We'll speed through the rest, so don't worry. It's just this is important, okay? Now, category 1 can use 100%. Category 4 is not to use. No, it's absolute contraindication to use combined oral contraceptive pills. Even if you use combo with progesterone, it will not protect us. 2 and 3 are gray areas. So 2 is benefit more than risk. So you can give it, but you just need to follow them up really well. Category 3 is risk more than the benefit. Okay. And yeah, wait, I am just checking again if I missed anything from the notes. Okay, so Now we said for if we want to use it, if we can, I mean, these are the situations where we can use it. So up to 40 years. So postpartum is an postpartum more than 21 days. I'll come to this. So post abortion, you can use it. Anything that is normal, it's okay. You can use like fibroid, iron deficiency, anemia. There's nothing stopping them. Everything that I mentioned before, like endometriosis, painful periods, right? What is important is to know the difference between these. So you see here, age more than 40 becomes a gray area, but you can still use it. Obesity, someone who is having more than or equal to 30 BMI, you can still use it, but try to follow up. Hyperlipidemias, all these effects, all these side effects, be careful. Heart disease, hyperlipidemia, diabetes that is uncomplicated, you can still use it. Now, what is the difference? So, postpartum, more than 21 days, you can use it. Less than 21 days means absolute contraindication. Wait, sorry. This is okay, I'll change it. This is supposed to be postpartum, less than 21 days. So breastfeeding and postpartum together, I guess. And what you don't want to use it in is someone who has visibly like not valvular, it's like stroke, someone who has artery disease, severe hypertension. You see here, where's hypertension? Controlled hypertension is gray area. It's still a risk, but if they are severely uncontrolled, it's absolute contraindication. Let's talk about migraine. Migraine without aura in general is a gray area, depending on the age. With aura, um, not without any age, if someone has migraine with aura or stroke, sorry, with aura, you absolutely do not use oral contraceptive pills because estrogen can increase the risk of migraines, and this in particular can increase the risk of stroke. So people who have confirmed thromboembolic, major surgery with immobilization, suspected pregnancy, do not give combined oral contraceptive pills. Someone who is hypersensitive to these drugs, again. So another important thing, smoker who is more than 35 years old, more than 15 cigarettes per day. That's very specific, but I want you to remember that. You see here, smoker who is above this age, but less than 15 cigarettes per day is a gray area. It's more risky. There's also people with postpartum in between the 21 and 42 days. It's a gray area. And yeah, but it's not that you don't need to know really, but it's just in between, right? 21, just remember 21, 40 years, BMI, high BMI, 35 years for migraine, 35 years for smoker, 15 cigarettes for smoker. Okay? So that is the absolute. I would say just know this one, and then whatever falls in between is the gray area. Liver diseases, again, because we said they can cause gallstones and liver and so on. Liver failure is an important thing. So, if someone is early postpartum, less than 21 days, or they are breastfeeding, or they have hypertension uncontrolled, or they have diabetes uncontrolled, you can give progesterone only pills. The problem is because it's combined, and estrogen increases the risk for all of these. So give progesterone only. That is category one, which means you can definitely 100% use progesterone in these patients. Only progesterone only. Do not give combined. Okay? Now, okay, let's move on. So now we are moving to the rest of the oral pills, which is we talked about this in detail. It's very effective if you take in the time, right? There's oral, so progesterone only pills, which is low dose. And then, yeah, okay, we'll talk about this. So progesterone only can be used in these situations. So things like Opil, you'll hear these names a lot, but basically progesterone only. Gestrel, again, remember this, drospirenone, okay? What is the key feature for this? Is that it's taken daily. It has to be taken daily. So Opil has to be taken daily at the same time. There's only a 3 hour window like where you are safe, but you have to take it within the same time. So let's say someone is taking at 3 p.m., they have to take it 3 p.m. or 3 hours before and after 3 p.m. But it's very short window, so it's mainly and it's throughout the entire cycle. So there is no placebo. So throughout the cycle, you keep taking progesterone only. Desogestrel is 12-hour window, drospirenone longer, 24-hour window. No need to know that drug combination, but 24-hour window. So longer window, but still you have to keep taking it daily, strict timing throughout the cycle. What are the benefits? They are safe in breastfeeding, safe in all the things that we said here. So older women, hypertension, thromboembolism, but they are less effective in controlling like pregnancy, or and they have poor cycle control because they have very strict timing. So if someone misses their pill, it can cause someone to become pregnant, right? Now, what if the dose is high dose progestin? This is this is in situations where, so again, you don't want to give too much, but you can give one dose, right? Only one single dose of high dose in cases of emergency contraception. What that means is if someone has unprotected sexual intercourse, for example, they did not want, like, they had a fail, like they forgot to use a barrier or something, or it was an unwilling action. It's it's good to use contraception one time, like one dose and a high dose to prevent pregnancy. Now this also has a window. For example, so main thing is it prevents ovulation, fertilization, implantation, and it's mainly progesterone again, but we'll see the types. So within, so if we were using levonorgestrel, which is a second generation progesterone only, it is over the counter, you can find, they can find it, but within 72 hours of that unprotected intercourse you can give, and it will work. Okay, so emergency use, and it will work in preventing pregnancy. If you are using something called ulipristal acetate, which is again another form of progesterone, it's within 120 hours of that intercourse that you should give. Another thing, copper IUD, copper insertion device that we talked about, the as a contraception. Uh, it can also be used as an emergency use because you can just insert it within the 120 hours and it's the most effective. But you need someone trained to do that because you need to insert it, right? That's the only disadvantage. But it is very, very effective. So we talked about, let's see, oral, combined, progesterone only pills in someone who is contraindicated to use the combined, and post low dose, and then postcoital emergency is high dose progesterone. Okay, remember that. And these are the windows, three different drugs. This is strict timing, these drugs, right? So daily, so low dose, one dose is you can give high dose progesterone to prevent pregnancy. Now, these two are good when you have estrogen being contraindicated. Okay, these two. Okay, let's move on. And emergency contraception, this is from your slide. Basically, this is the window where, let's say that like the intercourse happened, you just want to make sure that levonorgestrel has the least like window, copper has the most, copper and this has the most. But these two, like the most effective is the copper IUD. It's more than 99% effective, and you would go for this first line. Okay, that's more mainly it. The another thing is that copper IUD is not affected by someone who has high BMI, but the adverse effect is that it can cause heavy bleeding because you are inserting something foreign in the uterus. It makes sense, right? Levonorgestrel is affected by BMI, so it is affected by BMI, has a shorter window, less efficient. Okay. Now, I hope that all made sense and it's easier to digest. Injectable, so we finished oral. Injectable are contraception that can you can that the woman or someone can inject and it will work. So you can give estrogen, progesterone combination, we'll see. The main thing about injectables is that they are depot. So depot, or I don't know how to pronounce it, but depot are usually given deep into muscle or subcutaneous, and they act over a long period of time. So that's why they're very good and they're very effective than taking like pills a day, for example. So the first one is DMPA, which is depot, from the name depot, depot medroxyprogesterone acetate. From the name, progesterone only. Again, injectable. So just remember, IM, intramuscular or subcutaneous, doesn't matter. You don't need to know. Every 3 months. So they can have one injection every 3 months, and it will be working fine. First 5 days of menses, yeah. So it is safe. It is good for again, progesterone only, safe for women above 35 years, for smokers, for breastfeeding, postpartum, everything, every contraindication. 99% effective. Okay, so this is effective, injectable. If we go, oh, sorry, I don't know how to go back, but if, sorry, yeah, here. So copper IUD is most effective in emergency contraception, so just don't forget those two. Okay, this is effective in this table. NETEN is another combination, norethistron enantate. It sounds like estrogen, but it's terone, so progesterone only pill. This is every 2 months, less effective than DMPA. So you would prefer that first line. You can also have combined estrogen progesterone injectable every month. Again, monthly is more frequent. It's similar to oral, it's just injectable. This is good when estrogen is contraindicated again because progesterone only. Just I keep saying that. What is the benefit of pill over injectable? You would think that this is better, but sometimes pill is better. Why? So advantages that were mentioned on your slide is that pills are more private than a visible, like visibly taking the shot or visibly taking the having a patch. Um, Pills are uh so these are less effective if someone is over 35 BMI, so obesity has a play. Injectable might not always work. Like again, I'm talking about the patches as well now. So pills are better than these two options because patches can detach, they can go out sometimes. There is another thing in patch, so I'll mention that in a bit. So basically, remember the transdermal patch that I mentioned? It has a higher dose of estrogen than the pill, so that increases the risk of venous thromboembolic uh, event. So you don't want that to happen. That's why pills are more preferred, even though you have to take daily. It's like pros and cons. So another thing for injectable, moving back, they have if someone so wait. Yeah, so it can cause amenorrhea, bone loss if you're only using progestin. So it's a category 2. You can still use it. So wait, actually, so if someone has amenorrhea, bone loss, um, it's like the benefit of using this is more than the risk. So you just need to follow them up. That was just mentioned on your slide. Nothing too important. Okay. Yeah, but that's mainly it. Amenorrhea. Yeah, so you can still use DMPA. Okay, so non-oral route, non-injectable, rule of three. Just remember, you will see three everywhere. So three, three, three. This one I'll talk about it in a bit. So transdermal patch, remember we said better compliance because it's weekly for 3 weeks of menses rather than pill daily. No need to swallow, comparing it to pill, not to injection. Lower doses, avoiding first pass, sorry, and yeah, and constant hormone levels. Oh, I'm just trying to make sure of the pill, like, because they said that in the slide there's a possibility of increased risk of venous thromboembolism in, oh, okay, in patch users. So they are lower doses. Sorry about that. So they are lower doses individually, but total, because you are taking it weekly, total estrogen is higher dose than the pill. Okay, total. So, but generally lower dose, constant hormone levels. It's more steady than having it taking a pill and having it increase decrease. But side effects are mentioned in the notes, which is what I said, why you prefer pills over patch. So the patch is a combination of estrogen, progesterone, any number of combination, weekly for 3 weeks, and then 1 week off. Okay, so 3 weeks, you continue take doing the patch. 1 week you remove the patch. That's how like the on and off rule, just like the pill, right? Vaginal ring um is the ring that I talked about and placed in the vagina. It can be only progesterone plus minus estrogen, but it's less effective in, again, high BMI. Uh, so same thing, 3 weeks of cycle. If you're using the one with estrogen, there's a specific name of the drug. You don't need to know that, but that is like that one specifically can be reused over a year. Advantage is like it's monthly, again, 3 weeks, right, of cycle, 1 week off, self-inserted, steady levels of hormone. Subdermal implant, which is under the skin, is progesterone only, and 3 years of that can happen, and it's the most effective and it's safe. But there is irregular bleeding, breakthrough bleeding, like we mentioned with progestin. All of these side effects we already mentioned in the oral, it's the same. Progesterone and estrogen side effects. Intrauterine hormonal device is progesterone only, the levonorgestrel, and duration is 5 to 8 years. The side effects I mentioned already, the progesterone, right? It can cause breakthrough bleeding, the most common, and the other things, fatigue, moods, and so on. So this is the under the skin, this is the vaginal ring, this is the patch on the skin. This the device is inside the uterus, which I showed you before. So these two, subdermal implant and intrauterine device, are called long-acting reversible contraception. So LARC, so long year number of years and reversible. If you remove them, you will someone they will gain back their ability to become fertile or fertility, right? So this is the effectiveness summary. So they calculate effectiveness is something called Pearl index. So the lower number or lower pregnancy of women using these, lower number of pregnancy that happens means it's more effective because the contraceptions are working. So, and less pregnancy, right? So the most effective over a long period of time, first line is implant, or in this case, yeah, progesterone only implant. Then you have the IUS, which is intrauterine levonorgestrel. Then you have copper IUD, which is not in the hormonal lecture, but it's still effective. DMPA, so we move from implant. So this implant is the most effective, okay? Maybe I should make that green. And then this one is the next one over a long number of years. So LARC is always good. Then we move to injection, then we move to combined pill, progesterone only pill, then the patch, then the ring, then the barrier methods, and so on. It's not that effective. So that's which is why we resort to hormonal. So offer LARC first. Offer these two first, which we mentioned here, right? Okay, so this is great. So okay. Progesterone synthetic preparations come in different generations. Which of the following is the reason for this classification? I will move on. First gen, second gen is due to androgenic activities. I'll move through the questions quickly because it's a recording. 35-year-old woman, 2 months postpartum, currently breastfeeding. Which one is the most appropriate contraception? So, a lot of things. 35 is on the borderline age. 2 months postpartum and breastfeeding. I'm concerned about that she's breastfeeding. So we said in breastfeeding and very early postpartum, right? 2 months is around maybe 24 days, which is more than 21 days, I understand, but she is still breastfeeding. So you only want to give progesterone. You do not give estrogen because this is category 4. Okay? Now let's move to, okay, I'm just going through the questions. So young woman complains of abdominal pain at menstruation, shows significant endometrial deposits in the uterus. Which is the following is the most appropriate medical therapy for this patient? Now, so we have painful periods. We want to give birth control pills. That is our next step. So what do you do? We didn't talk about fulitamide. We didn't talk about this. So you can this is injection progesterone. So we didn't talk about laroxetine. But from these three, the most effective we said is IUD, right? We did say that. But because the problem is in the endometrius, what do you think the answer should be? It is the injection. So even though IUD and IUD is a LARC, it is more effective, but in someone who has what do you call it, bleeding, active bleeding, they have something in the uterus that is physically not letting you do IUD, go with the next more effective, which is injection, and then the pills and so on, right? But do you get what I mean? This is DMPA. DMPA was the most effective from the injection table, so go with that, depending on the scenario. So yeah, that I hope that made sense. Like you cannot use the uterus. Which of the following is a side effect of estrogen not found in progestin? Unique hypertension. Everything is together the same. Long-term contraceptive. They want a highly effective long-term, so over months. She does not want to worry about pills or monthly visits, and which of the best suits her. So we said Lark, right? Remember that all the time. That is the first line. If there's no contraindication, nothing in the uterus, so we will go with implant. We said that is the most effective in the top of the chart. Okay. Okay, which of the following factors would lead a health professional to recommend alternative form of contraception? Read through these. The most important for us is migraine. So combined oral, you do not want migraine headache is very risky. Even if it's controlled, if they have aura, it's not good for giving that. Which of the following absolute contraindication? Again, I'm repeating undiagnosed vaginal bleeding because you do not know what's happening. This was in the beginning slides with even the hormone replacement therapy, you do not want to give someone with undiagnosed. 26-year-old, sorry, wait, yeah, let me just check. Yeah, so 26-year-old for asking for hormone or contraceptive. DIC followed an abortion. Which of the following is the most hormone contract? So DIC is a thromboembolic like event for sure, confirmed. So you do not want to give estrogen at all. So remove estrogen from your choices. All of these are estrogen, estrogen, estrogen. Mifepristone we did not discuss. It's an abortion medication, so not used here. So we will go with progesterone only pill. Okay. Okay. Synthetic estrogen progesterones are used, even though we said we prefer natural, we can still have synthetic, but what is the this is something new. So synthetic over natural, what is the advantage? It is that they have greater oral viability. So that means that they are more like you can give it for a lower dose than natural hormones because natural hormones tend to get metabolized by the liver, whereas synthetic, it's more you can play around with the structure. You can make the hormone so that it's more stable, if that makes sense. So it's stable, it can be metabolized less, and it can be absorbed more by the body. Okay, that is something new, and you can cross out the rest. There is nothing different, no risk factors. Okay, I've added risk factors. Okay, moving on to the next lecture, which is labor and yeah, labor, uterotonics, talk. Okay, so labor in general. So labor has three stages. Stage one, contraction of the uterus. Stage two, expulsion of the baby. Stage three, expulsion of the placenta. Now, you can either induce labor for someone who there are many indications or stop labor. So this is induction. This is tocolytics are stopping someone from laboring. Let's talk about more about the like what happens during the labor, like what why do we like have all these, so what the effect of these medications are. First, in pregnancy, we do not want labor to happen prematurely, right? So in pregnancy, we have progesterone that is very, very, very high all the time. This, you don't need to know the details. This is exactly from your slide, but it's completely fine not to know the small, tiny details. I'll just explain so you know. Progesterone is very high in early pregnancy, which keeps the uterus firm and not contract. It keeps the baby growing inside. Why is that? Because there is a certain receptor called progesterone B, which is more dominant. It kind of um, like keeps the uterus firm, like I said. Why? Because so it depletes or reduces the oxytocin receptors. So oxytocin is the hormone from our posterior pituitary gland. If you remember, it contracts the uterus, stimulates milk production. So it helps with labor, oxytocin. If the oxytocin receptors are less because of the progesterone, there's also no gap junctions, cervix is firm and tight, there will be no labor. And the pregnant woman is good throughout pregnancy. Let's say she reaches her term, 37, 38 weeks. The placenta on its own, it's a clock, it releases a hormone called corticotropin releasing hormone, which is CRH, which will release DHEAS, which ultimately releases estrogen. So estrogen starts the switch to labor. What happens in labor? Estrogen becomes more dominant with the PRA isoform, not PRB. So A is active, estrogen. Um, and that receptor is overexpressed, which helps in oxytocin receptors being upregulated, gap junctions from forming, and cervix being ripe. What I mean by ripe is cervix becoming loose and ready for labor, ready for expulsion of the baby. Now, this is why exogenous oxytocin, when you give someone oxytocin from the outside, it only works when the person is at term because of these receptors. Before that, if you give oxytocin to someone who is pregnant at 20 weeks, 21 weeks by mistake or something, there are no receptors. So the woman will not be induced labor, like there will be no induction of labor. What happens when this labor happens? There's three things. So oxytocin, we said signaling from the posterior pituitary gets released, acts on the receptors. We will go over this process in a bit. And it stimulates calcium release, which contracts the uterus muscle. The uterus muscle, so you want it to contract for the labor. There is also prostaglandin release. Prostaglandin, I like to not confuse that with progesterone. So prostaglandin is like loser name for, like, it makes the uterus more ready. So PGE1 or PGE2, sorry, and 2 alpha, they act on these receptors to make the cervix ready. And also calcium, again, like I said, L-type calcium channels, gap junction, all these cause synchronous contraction of the uterus, meaning the uterus contracts all together to push the baby out at one time. So this is coordinated labor, which can take place. Now, these are receptors that we talked about: oxytocin receptor, prostaglandin pathway, calcium pathway. Progesterone receptors also. But the main three are these three. And these three are the things that we want to tackle in terms of pharma. So induction of labor or stopping labor, you can give oxytocin agonist or antagonist, depending what you want. Prostaglandin, so they have short lifetime, for example. Prostaglandin pathway, if you want to block labor, you can give dinoprestone, carboprost, which are both uh, sorry. Oh, no, no. So, yeah, sorry. So dinoprost and carboprost, if you give prostaglandin, it will stimulate labor. So they are uterotonics. Calcium here, nifedipine, these are tocolytics. So these stop the labor. So because they block the calcium channel, right? Calcium channel blockers. So what happens at the molecular level? I mentioned all these receptors and calcium. So it's important to know for these drugs. In short, you have increase in calcium from the sarcoplasmic reticulum in the cell, which will go and activate calcium calmodulin and the myosin light chain kinase activation MLCK pathway with the calcium. This is basic science, to be honest, but just for you to know, which will cause myosin phosphorylation because of the kinase, right? Phosphorylation, which will cause actin and myosin cross bridging and the contraction of the muscles. And this will go over all the gap junctions and contract the uterus. Now, how is this calcium increased from the sarcoplasmic reticulum? You have oxytocin receptors. Oxytocin from the posterior pituitary acts on this. You have L-type calcium channels just bringing calcium in directly. So oxytocin receptor and prostaglandin receptors converge on phospholipase C pathway, which is the IP3 and DAG, and that will stimulate calcium release from inside the cell. Now, there's another thing called beta 2 agonist. Beta 2 agonist is another receptor on the same cell on the uterus, which will have another pathway of adenylyl cyclase, which is cyclic AMP, protein kinase A, which will cause actually the opposite thing. So it inactivates the MLCK pathway, which we talked about. So MLCK is the most important thing. If it is blocked by cyclic AMP from the beta 2 agonist, then it will stop the labor. So that is how these drugs work. They are tocolytics. Whereas something that so prostaglandin stimulation, oxytocin stimulation will induce labor. If something is blocking prostaglandin, like these denoprost, misoprostol, blocking oxytocin atosiban, blocking in prostaglandin, like sorry, not this one. Blocking prostaglandin is endomethacin, which is an NSAID, but it blocks the enzyme that releases so COX-2 inhibitor, which is the enzyme, it inhibits prostaglandin synthesis in the first place, so it reduces the labor. Okay? I hope that makes sense. This is the whole pathway, and it's in the notes as well in details. Just know the three different receptors. If you need induction, you need to stimulate oxytocin prostaglandin. If you need to stop labor, you need to inhibit oxytocin prostaglandin, stimulate beta 2 agonist. Okay? Now, okay, so induction of labor, what are the indications? You have post-term pregnancy, which is more than 42 weeks of gestation, preterm labor, preeclampsia, HELP syndrome. So anything that is causing damage or preterm labor, diabetes, restriction, abruption, induced labor, you can do that. Contraindications of induction of labor. So we are talking about induction of labor. If someone had C-section before, prior rupture, placenta previa, active lesion, you do not want to induce labor. It's better to just do C-section or something because these will affect, right? You don't want the baby to be affected with herpes. And if the position of the baby is not right in the first place. So there is something called Bishop score. So Bishop score assesses the readiness of labor. So based on, again, it's too much in detail now. You'll take this in OB/GYN, but dilation, effacement, station, consistency, position. Basically, if the baby is ready to be pushed out or not. Just remember the number six. Six is your magic number. If the number is more than six, it is ready. If the cervix is ready. If it's less than six, it's not ready. So there are two different things that you can do. So if it's less than six, I would say less than here five, it says, it means the cervix is not ready and you need to ripen it first. You need to make it ready by giving prostaglandins, Foley catheter, anything to make the cervix ready. You cannot give oxytocin yet because it's not ready. It does not have receptors enough, right? Remember? So it's better to just give prostaglandins because of that reason. If it's around the number like six, seven, eight, you can do again prostaglandins. Again, anything less than six, try to increase the readiness by increasing the cervix, so the prostaglandins. If it's more than six, more likely more than eight, you can go straight to IV oxytocin, which is the receptors are high. You can start giving that, or you can do amniotomy, which is like rupturing of the membranes, because it's already ready to for labor. Then the active labor is established. Okay. Now, okay, so we will talk more about oxytocin, prostaglandins, and then we'll go to questions before we move into the stopping labor. So this is induction of labor. Oxytocin or syntocinon, which is a synthetic form of oxytocin, can be only given in Bishop score more or equal to 6, effective only at term No, because there are no receptors before then, and it cannot ripen the cervix. It has to be above 6. So the mechanism of action, I talked to you about it before, the receptor, which is G protein, through the IP3 DAG pathway, calcium channel, and contraction. Uh, High, okay, so we'll move to this. Increase dose will increase the frequency and contraction of the uterus. This is what we want. We want to contract the uterus. So important thing, very short half-life. It acts very, very quickly. If you give it, it contracts the uterus if it's ready. I've seen those in OB/GYN and like in people who are about to deliver or yeah, in at term. So it's very interesting. You only give it IV infusion pump by pump, like continuous. You do not give with bolus because bolus, like giving it once at a time, causes hypotension, and you do not want that in pregnancy. You want to give it constant, steady dose of oxytocin. Uses induction of labor, everything. So augmentation, prevention of. Okay, so here, these are the uses: induction of labor, augmenting labor, helping someone who already is in labor, or postpartum hemorrhage. Postpartum hemorrhage is a condition in which the so after delivery, the uterus fails to kind of contract. It needs to contract to stop the bleeding, but it keeps bleeding out. So you want to contract that uterus even postpartum, and that's when you can use oxytocin again. So keep monitoring the baby heart rate, contraction frequency, maternal blood pressure, signs of uterine rupture. Why is that? Because there are side effects of oxytocin. Side effects of oxytocin, most important, is tachycystole, which is risk of like so more than 5 contractions in 10 minutes is definition of tachycystole. A lot of contractions happening at the same time is not good for the uterus because it has risk of uterine rupture. So if that happens, if you see that on the chart, the CTG, stop the dose or decrease the dose of oxytocin immediately. Again, oxytocin is related to ADH, if you remember, in the posterior pituitary. So they can have some resemblance to ADH symptoms, which is hyponatremia, low salt in the blood. So that risk is high. If the dose of oxytocin used is high, and for long hours, it can cause headache, confusion, seizures because of low sodium. Again, stop oxytocin, restrict water, give saline, hypertonic, salty saline. That's why you want to monitor all these. Now, if you give rapid IV, remember it can cause hypotension. So don't give that. Prevent this by always using infusion pump. And then uterine rupture due to tachycystole, they can have sudden loss of contraction, abdominal pain. Try to stop oxytocin if that happens or if there are warning signs. Okay, so here's another picture to show you that the oxytocin drugs only work at term. Atosiban, which is oxytocin antagonist to stop labor, can work at preterm because there's slight receptors, right? So it can stop the labor from happening. But generally, oxytocin for labor works after term. Okay. Prostaglandins, if the cervix uterus is not ready and you want to induce labor for a number of reasons like abortion, you want to induce labor in other for other reasons, you can use prostaglandins to keep that cervix ready, and it is effective even in second term because the receptors are always there. I talked about mechanism of action. We said the COX enzyme turns arachidonic acid to prostaglandins, which is this, causing the contraction and softening. PGE1, PGE2 are the ones that we use, the medication that we use, the prostaglandins, which will contract every uterus, even if the person is not pregnant. Sensitivity of, yeah, okay. So they increase with time, the receptors, but they're always there. COX inhibitors like indomethacin and SIDS will delay the labor. So this is a tocolytic, but yeah, I just put it there. Prostaglandins are usually for induction of labor. Main two drugs are the ones in green. Um, Let's talk about contraindication. We said we do not want to use in prior C-section. Side effect is the same, tachycystole, and then minor side effects like fever, GI. Doesn't have the other side effects of oxytocin. So PGE2 and PGE1. PGE1 is commonly used. It's called misoprostol. Okay, PGE2 is called dinoprostone. similar to progesterone. See, so I like to keep that in my head. That dino like dino and miso like the food. These are um prostaglandins. Just remember that prostaglandins. They can be given here. They are different formation like vaginal insertion, endocervical. No need to know. This is vaginal or oral. It's fine. But basically, they are approved for cervical ripening as they are prostaglandins. Misoprostol can be used for second trimester termination for abortion as an off-label, and it's more cheaper and more stable than this. So one is more cheap, one is more commonly used. It is also approved because it's the number one. It has another effect on gastric ulcer. Remember, it's an NSAID, basically, like you are using NSAID related thing. So in the stomach, it also can prevent gastric ulcer. Postpartum hemorrhage is something that I mentioned. It is a cause of or indication of contraction of uterus. You might want to use that. And the combination that we use is methyl. So okay, wait, let's talk about this. So let's say someone is bleeding out after giving birth, and the first step that you want to do is massage the uterus, and oxytocin is first line. Even if don't care about the bishop score now. If that doesn't work, you can give tranexamic acid, which is like an anticoagulation of sort. Like it kind of contracts the uterus and keeps the blood in one place without being too thin. After that, you can use other uterotonic agents like methylargonovine or carboprost or misoprostol, the misoprostol from prostaglandin. So they can work. The only contraindications are methylargonovine is contraindicated in hypertension, and carboprost is contraindicated in asthma. So prost, I just like to know it as like in asthma, we don't like to use things with that. So, and it's a longer name, so it's just how it is. And then other, if those don't work, you can go into surgery and to stop the bleeding from the postpartum. Let's move to questions. A woman in childbearing age had been labor for the past day. Um, okay, so wait, sorry. I'm just trying to check. Yeah. So, what is the best next step of management if the bishop score is 7 and you want to induce labor? You can give in slow IV infusion pump oxytocin. If someone is having had oxytocin and they are having increased frequency contraction every 2 minutes, remember I said 5 in 10, that's tachycystole. What is the next step in management that you want to do? You want to reduce or discontinue until this tachycystole resolves. 40 weeks gestation, bishop score is 4, not ready. What do you do next? You give prostaglandins, right? Which of these is the prostaglandin? It is the intravaginal dinoprostone, right? Um, Oral misoprostol is uh wait, actually it's fine, but I think dinoprostone is more like it's better to use. I would say, wait, sorry, I will just see. It's also much easier than giving orally at this point. So yeah. Wait, sorry. Oh, that's the reason why I put this one before this. I think PGE2 is more used. PGE1 is more used for abortion. So that's the difference. Yeah. This is more over the counter. So for induction of labor, the Dino or the Dino, that one is used more. Okay. Now we will move to Tocolytics. Just give me 1 second. Sorry. Okay, so let me continue. Yeah, so I was, yeah, talking about this. Sorry. Okay, so let's continue. Okay, so we talked about yeah, uterotonics. Now we'll talk about tocolytics, which is this is the one slide, a summary table that you need for tocolytics. Basically, for tocolytics, it's to delay delivery. If someone is premature, like they are giving labor too early and you want to delay it, right? So you have to give other like corticosteroids. It's not important for this lecture, but yeah. Now, the four tocolytic drugs acts on the receptors that we talked about. uh, Prostaglandin inhibitor, so COX-1 inhibitor, indomethacin, they decrease prostaglandin, and they have these side effects. The important thing for you is to know the type, the when you can use it, and the side effects that are highlighted. Okay, so again, calcium channel blocker is the most used. It's oral, it's easy. It like directly stops the calcium from coming and contracting the muscle, which makes sense. So calcium influx. Beta 2, the agonist. So if you stimulate that, you will block the by the CAMP pathway. Remember, it will block the MLCK pathway. Then you have oxytocin. So you want to antagonize it by atosiban. So ban is like you're banning the oxytocin. Um, and that is stopping the oxytocin from contracting the uterus. Okay. Now, all these four, we mentioned the mechanism. So, what is the timing? Oxytocin is everything O, like everything is okay, So, all gestations are fine. Remember, in tocolytics, you want to give it bolus, then infusion. So just remember that difference between induction and delaying labor. But yeah, all gestation, this is the easiest. So let's start with that. Side effects, not much. It's just injection site is the main thing. Nausea. Again, it's safer in cardiac patients. It's not that much. There's nothing significant. Let's talk about indomethacin, which is prostaglandin, like NSAIDs, prostaglandin decreases. You can only use this if the patient is less or equal to 32 weeks. If they are above, you can use nifedipine. Why is that? Because NSAIDs, they have a vasoconstrictor effect, so it constricts the ductus arteriosus, which is usually open in babies. But if you close that too early, then it's not going to help them with their circulation and breathing. So it will cause pulmonary hypertension, tricuspid. So you can only give it less than 32. If you give it more, it will cause this. And as well as oligohydramnios, by decreasing the blood flow, again, circulation is affected. So the urine will be low, fluid volume will be low, oligohydramnios. So it's important that you do a fetal echo just to make sure if someone gave it above 32 and they didn't know their gestational age. Other side effects are okay, but they're again GI upset, hepatic, they're not significant. Nifedipine, which is calcium channel blockers, you can use it 32 to 34 weeks, but they can cause very severe hypotension because they are the opposite. They are vasodilators. So they are most commonly used. They are vasodilators. They can increase stroke and heart rate because of that increase in like vasodilation and the volume from being pregnant as well. So, what are the side effects of hypotension? Dizziness, palpitation, headache, nausea, and flushing will be the signs in nifedipine. What about terbutaline or ritodrine? So terbutaline is a beta 2 agonist. It is not first line because a lot of them, so they will have the same effect as nifedipine. Again, not that used, but they will cause vasodilation in the cardiac plus severe effects. So that's why we don't commonly use it, which is metabolic. So they will have hypotension, reflex tachycardia, and hyperglycemia, hypokalemia, lipolysis. Anything metabolic, you know that you're giving, that is the side effect of terbutaline if you see. So hypotension because vasodilation, hypokalemia, hypoglycemia in the fetus, lipolysis, but hyperglycemia in the mother, which will cause that whole process. So hyperglycemia causing insulin release and so on. One way to remember that is because beta 2 is not selective. There's like hundreds of beta 2 receptor agonists in your body, like uterus and so on, right? But beta 1 is also there. So in the heart and so on. So your heart rate and stroke volume will both increase because it's non-selective. Okay, so 32-year-old pregnant woman experienced early birth contractions. They want a tocolytic drug. Next day, she came with flushing, palpitation, dizziness. Which one was used? nifedipine, right? What is a common complication? It is, oh, I have it in the notes, hypertension. Okay, 29-year-old pregnant woman for the first time presents to, okay, 30 weeks, painful uterine contraction. This is too early, which is the first line option at 30 weeks. Let's say there's no other contraindications you can give in the medicine. What is the side effect if used outside the safe window? Remember ductus closure, early closure, and the oligohydramnios from the kidney. So it's affecting the circulation. That's mainly it for Tocolytics. No, there was not much. Hopefully there's two more. So drugs used in pregnancy. In pregnant women, it is very important to consider that there are a lot of physiological changes. The ones in green are increased, like plasma volume, cardiac output, renal blood flow. Like the woman is urinating more, having more edema, more bloating, more body fat, even, right? And then they have less of the others. So less albumin because of dilution of the blood, and less gastric emptying, so they like empty slower because the progesterone is relaxing all the muscles including the stomach. What about the enzyme levels in the liver? That is variable, some increase, some decrease. So you have to be very careful when prescribing drugs and knowing what is safe and what's not. Now, the other thing that I want to mention is, so according to these, you have these effects. So there are, you need higher dose, you need faster IV onset because of your heart beating faster and more. Faster renal elimination, so you need more dose, especially for renal eliminated drugs like heparin, lithium. Because of the body fat, lipophilic drugs, the ones that like fats, they will persist in the blood long. So you need to consider reducing the dose or not even giving them as things like isotretinoin. This is actually contraindicated, so we'll see. Now, if, for these ones, you have, if albumin is less, you have more free drugs because they're not bound to albumin, so they are more active. Especially if they cross the placenta, you have to be careful. This one, slower gastric emptying means slower absorption, and it will go, for some it is faster, but some slower. There can be constipation. All these symptoms of pregnancy are related to progesterone being like relaxing the muscles. Then the liver, it's unpredictable, so you need to do narrow like therapeutic index or therapeutic drug monitoring. So where you measure and monitor the drug because you are not sure what will happen. Now there is this thing in pregnancy where if you have a condition like asthma, hypertension, you have to treat it. And it's always good to treat it rather than not treat it. So there are some drugs that are safe in pregnancy and some that are not. So just make sure to know. So what about so there's two things. So we said considerations, placenta, molecules or medication that are big, size, lipid soluble, small in size, lipid soluble, non-ionized, non-polar, not bound to protein, and increased maternal blood flow. All of these contribute to these passing through the placenta. So warfarin, for example, is contraindicated. War is like, you cannot give that, right? War is bad. Small and lipophilic, direct oral anticoagulants comes with warfarin, you cannot give it. Anti-epileptics are lipophilic, so they will cross the placenta. Metformin for diabetes, glyburide diabetes, they will pass because they are small, and most other antibiotics will pass. However, heparin, low molecular weight heparin, which are large and charged molecules, insulin for diabetes, will not pass and they are safe for pregnancy. Now, there's another active transport called this PGP. Uh, so this is present in the uterus itself. Yeah, so I'm just trying to, yeah. So the PGP is present in the uterus and it acts as a barrier. So you can just remember that there is something there. Okay, it's usually a barrier. Now, timing wise, so timing of gestation. So let's say someone gave a drug that was not indicated in early pregnancy. In 0 to 2 weeks, the baby will most likely die. So all or none effect, die or survive. If it's within 3 to 8, which is the major, most sensitive part of pregnancy, where the organs develop, you will have structural defects like limb loss with a drug called thalidomide and so on, and heart and neural tube. So if anyone asks you what is the most important timing, it's this 3 to 8 weeks of pregnancy. From after 9 weeks, it is functional, so not limb defects, not structure defects. It's more of like how the body functions. So things like growth is affected, your neurodevelopment is affected, renal, cardiac, but not structure wise. It's just their function, causing oligohydramnios and so on. So if someone gives ACE inhibitor, which is a contraindication, it's an antihypertensive. If someone gives that in the first trimester, which is in weeks 3 to 8, it will cause limb or cardiac defects. But if they are given in the late one, they will cause renal failure and less volume of in the amniotic fluid. So not severe as limb defect, right? So that is the difference. So giving it at a certain time, giving a good uh, drug that does not pass the placenta is very important. Now, there is an old labeling called ABCDX in pregnancy, but now they moved to pregnancy and lactation labeling, which means let's take this example for sertraline, not important at all for this question wise, but this is how they come. They come with each risk summary, if you can use it in breastfeeding, if you can use it in other people. The old category didn't take into account breastfeeding, and it was just like you cannot give the X1, for example, and so on. And it was based on animal studies because not you cannot test a lot of pregnant women with trials. So, okay. So we'll move to what is preferred in pregnancy, what is not preferred in pregnancy, and then in the middle. If I were you, I would do preferred and avoid. Like I would memorize that, and then whatever is in between is use with caution, depending on. So there are a few tables, couple of tables. I tried to summarize the lecture as much as possible, but the ones highlighted are the ones she mentioned, and I assume that they are important. So let's say a woman is pregnant and she is asking for pain meds for back pain, neck pain, anything. First line, what would you go for normally? I will try to make it easy. Is paracetamol. Paracetamol is not contraindicated for even for pregnant women, so you can always use that. And it should be give again since they're pregnant, lowest dose, shortest duration. If it's clear indication, you can give it. Codeine, lidocaine, or other pain medications. What is important for you to know is to use with caution and this because NSAIDs, remember in preterm, it was not an issue to use until the endomethacin, until 32 weeks, right? Here, if it's for pain, because they're of a higher dose, you can't really give it more than 20 weeks. Okay, even if they're 32, you cannot give it if the indication is pain, not labor. So if more than 20, it will cause the same effects, oligohydramnios, premature closure. Why? Because it's a higher dose. If it's less than 20 weeks, use with caution. What about aspirin? Aspirin will cause bleeding, again, premature closure in the third trimester. But if you use baby aspirin, which is lower dose aspirin, you can still take it for patients who are high risk pregnancy, like preeclampsia. So you want to prevent like this from happening. You want to prevent the blood from thinning and like constricting blood vessels. So you can use baby aspirin. Opioids in general, drugs like opioids, benzo, like anti-epileptics, you'll see other, wait here, cannabis, alcohol. Just remember, rule of thumb, avoid in pregnancy. In opioids, if someone is taking opioids in the baby, it will cause something called neonatal abstinence syndrome, which means that the neonate, like the baby once it's born, it's will have withdrawal symptoms of not having that opioid that the mother was taking before in pregnancy. So they will come with symptoms like sneezing, coughing, runny nose, um, a lot of other symptoms like sleep problems, tremor, irritability, hyperactive, a lot of things that come with withdrawal symptom of opioid. There's also, yeah, diarrhea, poor feeding, a lot of things. Now, what else? Yeah, okay, that's what I wanted to mention. If the pregnant woman is hypertensive, like hypertension, you want to give something that are preferred in pregnancy. So methyl dopa, labetalol, avoided in asthma because beta blocker, nifedipine, which is also used in the Tocolytics. So nifedipine, you can give it sublingual under the tongue because it has still that risk of hypotension that we mentioned with the calcium channel blockers. This is gray area. You don't really need to know it. Hydralazine is part of it. What you should avoid is ACE, ARB, anything that inhibits renin by ACE because it will cause in first trimester cardiac defects in the limb and so on, remember? And the second one, it will cause renal failure and less amniotic fluid. So the ones in between are gray area. Beta blockers, metoprolol are preferred and so on. They can still cause some effects, which is why we prefer these. If someone is diabetic, remember first line diabetes, insulin. Insulin is fine in pregnancy. It does not cross the placenta, like we mentioned. What is used with caution are the drugs that do cross the placenta, which is metformin and glyburide. Metformin, glyburide, metformin, glyburide. These two can cross the placenta, and you can use metformin in PCOS, but use with caution. Glyburide can cause neonatal hypoglycemia and macrosomia, and you have to make sure that their BMI is not increased because of this medication use. Okay. What do you avoid? You avoid the rest. SGLT2, GLP-1, the ones that we use in adults, like avoid those in pregnant women because they are not studied that much in pregnancy. Antidepressants, someone coming with depression, SSRIs, first line, usually first line in pregnancy. So all these, it's easy to keep, like to know. So you just know, remember the name, sertraline, citalopram, check QT, fluoxetine, okay, QT prolongation. Use with caution are SNRIs. So venlafaxine, you took in psychiatry maybe, duloxetine, tricyclics. So cyclic TCA are not always first line in depression anyway, so you use with caution. Bupropion also used in smoking cessation, not used with caution here. Avoid completely is an SSRI called paroxetine because it will cause first trimester cardiac defects, especially VSD, ventricular septal defect. I don't know what the reasoning behind this is, but paroxetine is not good. It has an X in the name, so parox X don't use. The rest don't, right? I mean, fluoxetine does, but fluoxetine is a common SSRI we use. So paroxetine. And then benzo is also not good because it's used as an anxiolytic. It will cause cleft like problem, neonatal sedation, and withdrawal symptoms. Again, don't use that. And other drugs, MAOIs, monoamines, oxidase inhibitors. For antihypertensives, there's a mnemonic that I like. New mothers hate labor. So nifedipine, methyldopa, hydralazine is gray area. You can still use it. And labetalol. Most importantly is MLN. MLN. So new mothers and labor. No, sorry. Yeah, new mothers and labor. So let's go to nausea, vomiting, which is a common symptom in pregnancy. But if someone is coming with severe vomiting, this is called hyperemesis gravida. It's very, very bad. You want to treat it. Like you do not want to leave them alone. What is the preferred? You give them pyroxidine, which is B6, because with the vomiting they lose vitamin. So give pyroxidine, doxylamine, ginger. It's good. Gray area, not that important. There's things like metoclopramide that we use for vomiting and nausea, but they can cause extra pyramidal side effects if you remember, like dystonia and those things. Ondansetron, dimenhydramate, antihistamine is sedating, so don't use that. Use B6, use vitamin. Vitamins are always good in pregnancy. Avoid cannabis and alcohol, anything like that. Okay? Thyroid, you can give like levothyroxine, which is the normal treatment, and but avoid in general in pregnancy. You do not want iodine exposure, like radioactive exposure. So don't give iodine, and don't give excessive iodine. Obviously, you can give some, of course. What is used at caution? The most important, maybe you took it in endo pharma, but basically, PTU, uh, can be used. I'm forgetting the full form of PTU, but PTU can be used in the first trimester, and I forgot the name. I'm so sorry. Panto. Wait, let me check. And then basically you can use that in the first semester. So P for pregnancy, use in first trimester. And then when the woman goes into second or third trimester, so propylthiouracil, sorry, that's the name. If the woman is in second or third trimester, you move on or you switch to methimazole, carbimazole. The reason for that is PTU can cause hepatotoxicity and it's only used in first trimester. Methimazole, carbimazole in first trimester can cause aplasia cutis, which is the fingers not developing well and the membrane not separating. So you do not want to use that in first trimester. P for P, so use that. And then second trimester, use them because PTU has that effect later on. So it's a switch in, medication. Beta blockers are you can use that, like propranolol for symptomatic. Again, this is important. Asthma, everything is okay. Everything. Inhaled cortico, sure this, sure this. Inhaled drugs are all okay. Use with caution the oral ones only because they are steroids. That's mainly it. So, but the first line treatment for asthma, use them all. It's fine. Avoid stopping medication for pregnancy. Avoid live vaccines because they are on steroids at the end of the day, and avoid smoking. There's no drug contraindicated for asthma. For reflux, again, antacids are good. Calcium, magnesium, ions are good. Um, Famotidine is a H2 blocker in the stomach, so it's good. Lifestyle is always recommended. Use with caution, which is PPIs. You do not want to suppress that acid too much in pregnancy, as well as other antacids. That is not the calcium and of these things. So just remember calcium, magnesium, H2 is fine. But avoid sodium bicarb. Sodium bicarb is not always good for pregnancy because it can cause alkalosis and fluid overload. And magnesium, so magnesium alone is good. If you elongate that name, magnesium tricyclate, don't use it because it can cause too much iron, too much salt can cause stones and hypotonia, so don't use that. Another H2 blocker, but it's off the market, so you will not see that anymore. Ranitidine, it ran away from the market. It's not there, do not use it. Longer name of magnesium, do not use it. Longer name of sodium, do not use it. These shorter names, sucralfate, these things are cute and nice. There you can use that. Okay? So H2 famotidine is there. Um, Allergies and cold. Loratadine, which is what we use. It's an antihistamine drug. You can use nasal sprays, of course. Diphenhydramine causes sedation, so use that with caution. Don't use that. Intranasal steroids, which was okay for asthma, but for allergies, use with caution again, because it might not be indicated, and this is more helpful. And cough suppressant is fine. It was not mentioned in the lecture that much. Avoid pseudoephedrine. Why? Because in first trimester it is a vasoconstrictor. If you remember alpha blocker in the blood vessel, do not use that in pregnancy. Phenylephrine, same thing, vasoconstrictor. Do not use that. And then some pregnant women will take combination of cold products, like they will take over the counter, like a lot of things, like NSAID, Sudafed, alcohol, caffeine. So all of these can be a component in that over the counter drug or herbal medication. So this is very important. Like do not take combination of cold products all at once because you will overdose on something, then that is not good, right? So what you go with for allergies or cold, loratadine, which I believe is either second generation maybe, and this one is first generation. So diphenhydramine, I like to remember the word hen. I don't know, it just reminds me of first generation. It has the word hen in it. It causes more sedation than second, right? So that's why I use with caution. Now antibiotics important. All beta lactams, um penicillin. So all, by all I mean these three: penicillin, cephalosporin, macrolides, you are safe to use for any infection. What you should avoid are three main things from the lecture to know: tetracycline, which affects bone growth and tooth discoloration, so TT. tooth and tetra, and also the bone. So teeth is enamel and bone is calcium, right? So the same thing. Aminoglycosides or gentamicin can cause very bad ear like ototoxicity, renal. If you remember that from POD, do not use that. Gentamicin, even though the name sounds like gentle, do not use that. Aminoglycoside, tetra for teeth. Fluoroquinolones, also do not use that. Because like Cipro and Levo, because they will cause cartilage or joint damage, if you remember. So these three side effects from POD in pregnancy, it's even worse. So do not use that. These are fine. Now, use with caution in pregnant women with UTIs are usually nitrofurantoin because they can you should avoid them at term, but you can still use them if they have UTIs in second and third trimester. Why is that? Because they can cause G6PD or neonatal hemolysis. There's no way to memorize this, but nitro, I guess, nitrogen, nitro, these things are used with caution. Nitrogen gas. Trim sulfa, avoid first trimester because neural tube defect, and at term it can cause bad. So longer names do not use that. Other antibiotics do not use. The avoiding is more important. Now, oh, I'll change this. I don't know why it's the topic is that. Yeah, but supplements you can of course give folic acid, iron, vitamin D, calcium. I said right. But avoid one vitamin. If you have to remember, avoid the A. So retinol, vitamin A, do not use that. Iodine excess, do not use that. We said herbal mixes in cold, do not use that. So actually, retinol or vitamin A in acne, like isotretinoin, can cause major, major side effects. So A can cause like craniofacial, cardiac, CNS, thymus, abortion even. So only use topical agents or cream for vitamin for acne because isotretinoin is very like it's category like you cannot absolute contraindication. Why and how you have to make sure that the person is not pregnant before taking that. So you need two negative pregnancy tests and 1 month on contraception before starting this even. You need two contraception methods on isotretinoin so that to make sure the person does not get pregnant accidentally, and you continue contraception at least 1 to 3 months after stopping this because the effect will stay for a longer time, right? Because of the half-life. Do not do blood donations for isotretinoin because you can transfer that isotretinoin to pregnant women, so do not donate your blood if you are on isotretinoin. And if pregnant, it will, by mistake, you have to immediately stop it, and it will be a high risk pregnancy. So be careful. This is very important. That's why it's in a red box. Anticoagulants, we said this before. If you remember, I highlighted these because everything here is important. Preferred heparin. Anything low molecular weight heparin. Stop if they're laboring, but heparin, unfractionated heparin, fondaparinux, which is also another direct heparin. So they do not cross the placenta. You are good. Baby aspirin is good. We said switch medication cautiously, but avoid completely warfarin, direct oral anticoagulants that we mentioned. They cross the placenta, and other thrombolytics like TPA. So heparin is okay. Warfarin is not. Direct is not. Okay, this is everything that I mentioned. This is the summary slide, so you can use that to revise and, before your exam. So I'll not read this all, but basically, someone is taking isotretinoin, what to do about her acne, during which prenatal period is greatest risk for developing birth defect. So that is during the first trimester or 3 to 8 weeks, which is around day 18 to 55, right? This is live or die, and after is functional defects. Vitamin A is not, yeah, yeah, not this. 43-year-old woman recently diagnosed with endometriosis started treatment with metho. So this is from the other lectures, but I want to bring this here. Medroxyprogesterone, right? So she is taking a contraceptive pill for a painful period. Which of the following is most likely after a few days of therapy? What is an effect of progesterone? What is the effect in pregnancy? The consideration. It has to be increased body temperature, so not that. One effect is this. So they will have shortness of breath, increased ventilatory response. This is a side effect of progesterone in general, but I just brought it here because pregnancy was mentioned and so on. Okay. I hope that made sense. Nothing else is related. Not this, not sodium water. It's just shortness of breath. So someone had suspected pregnancy. They were on warfarin and amoxicillin, which is the best course of action. Warfarin is contraindicated. Amoxicillin, if you remember, penicillins are okay. Aminoglycoside is the one that's not. So replace warfarin with heparin, continue amoxicillin. 17-year-old woman asks her doctor what to do. So yeah, same thing. Isotretinoin. Can she take it or not? She is pregnant. So when can she take it? She cannot take it now. She cannot take it now. She cannot take it immediately postpartum because she has to be at least 1 to 3 months postpartum. It's contraindicated until then. Last lecture, breast cancer. Breast cancer is very important. There is a lot of drugs, but Dr. Santosh will most probably he will focus on the most important part. So hopefully it will be easy. These are all the drugs, all of them. So you have for breast cancer, you have chemotherapy agents. You see all of this here. You have targeted agents, so targeting hormones. Some breast cancer are hormone sensitive, either to estrogen, progesterone, or something called HER2, which is another receptor that is targeted. And then there are specific like antibody, other types of systemic like therapies. Okay. Now, most common for chemotherapy agents, cancer treatments is myelosuppression, decrease in blood count. That's just the way it is, like hair thinning, fatigue, diarrhea. These are very, very common, so I'll only go over the more things that are not common. Contraindications for chemotherapy is first trimester. Again, it affects cell lines, right? Like cell division. So you do not want to give it in someone who is pregnant and in first trimester where the baby is dividing and growing the more, right? More. So for chemotherapy, we will talk about these five. We have doxorubicin. Main thing that I will try to focus on, remember the red things, what it inhibits. And then remember the phase it acts on, and remember side effects and what can you do to reduce the side effects. So doxorubicin, adriamycin is AA anthracycline, not specific phase. These two not specific. These two are S phase where the DNA is dividing. This is M phase. Just remember that. So non-specific, it inhibits topoisomerase 2, which inhibits DNA transcription because this is the one that uh, opens the supercoil in the DNA. Okay, so it inhibits that cancer cells from dividing. What does it do? I put a heart here. So doxorubicin, ruby heart, right? Red heart. It can cause cardiotoxicity, like severe dilated cardiomyopathy. Myelosuppression is everywhere. Alopecia is everywhere. Typhlitis is inflammation of the cecum in the large intestine. I don't know how that is caused, but it's very rare and very deadly if that happens. So that is too important. So cardiotoxic, ruby, right, and cecum. What can you do to reduce or cardioprotect, right? Is a drug called dexazosine. He said he will not ask you, but it's good to know. Doxo and dexa is not that difficult, right? Cyclophosphamide is an alkylating agent, which means it adds alkylating groups to the DNA and literally damages the cancer cells. Phase non-specific, it acts on all phases of the cell division. I put a bladder here. So it forms, so this alkylating agent puts an alkylating group and it cross-links guanine to each other. Just know that irreversible, so it destroys the cells, doesn't in apoptosis. Again, same side effects. Bladder is like the main side effect, which is it can cause hemorrhagic cystitis, which means like blood and damaging of the uterus. What you can do to prevent this is give hydration, obviously water, plus something called mesna. So there is an agent in cyclophosphamide called acrolein, which is the one causing this whole thing in the uterus. But if you give mesna is detoxifying agent for acrolein. So it detoxifies this chemotherapy. Okay. Methotrexate, you might have heard it before. Both of these fluorouracil are antimetabolites. They reduce folate synthesis in two different ways. Methotrexate inhibits the rate limiting enzyme dihydrofolate reductase, and basically folic acid is important for DNA synthesis. So if you block that, if you block folate, you will block DNA synthesis of cancer cells. And then 5-fluorouracil inhibits thymidylate synthase, which is before the step, same process. It will have impaired DNA synthesis, same sort of symptoms, folate deficiency like anemia, weakness, so on. You can prevent that by giving folic acid to, not have the folic acid effect. So folinic acid, leucovorin are folic acid alternatives to give that to bypass this blocked folic acid. One thing for 5-fluorouracil, I will say, is that they have hand-foot syndrome. 5 and FU is a short form. It's like you can remember that as like foot or something, hand-foot syndrome. Okay. Now, so it has, I will show you a picture. Paclitaxel and docetaxel are taxane from the name. Taxane chemotherapy, it affects M phase, and they inhibit taxel, it inhibits the microtubule depolymerization. Just remember that. So, depolymerization and it arrests the cancer cells, okay? If it causes depolymerization is inhibited, what is similar to the microtubules in the cell? It is the nerves, the neurons. So their side effects are on the neurons, which look like microtubules, so you can remember that together, and taxil together, right? So this thin tube-like structures, they can cause peripheral neuropathy, same other symptoms. Neuropathy is the main general one. Now, these can be given as neoadjuvant, which means before, or as adjuvant. So before surgery, like neoadjuvant, or after surgery, or with surgery. And they can be used in breast cancers that are hormone receptor negative, triple negative, or HER2 positive, the other receptor that I talked about. Again, it's chemotherapy because you cannot target these negative ones. You can give chemotherapy to kind of irradiate the whole cancer. Okay, so this is what I said about methotrexate. Methotrexate blocks this inhibition of enzyme at S phase and this enzyme. At number one, which one inhibited it? Just remember this one. Fluorouracil inhibits the one step before. So this blocks the synthesis of purine, thymidine, methionine. What's this one? The one with guanine cross-link, um, and alkylating agent causing hemorrhagic cystitis with acrolein, cyclophosphamide, cycling of red blood cells, you can think of. What about the hand-foot thing? F, right? So that's the one that blocks number one, which is side effect of 5-fluorouracil. This is another diagram. No need to know all of that. I just got it to show you doxorubicin is cardiotoxicity, cyclo is the uterus, hemorrhagic cystitis. Okay, and methotrexate, all these are myelosuppression is common in all. Bisphosphonate is an area of research. They say that the side effects, you can use it to reduce it improves survival because it reduces recurrence in the bone, bisphosphonates B for B. But side effects are that it can cause bone pain, jaw osteonecrosis, again, bone, esophagitis, kidney injury. Not that important, but just know bone pain and it can help in the survival. So we finished chemotherapy. Now, targeted therapy, we can target HER2. If they have HER2, we can target that with Herceptin, which is trastuzumab. Now, just remember Herceptin is that it binds to the receptor, it reduces signaling, and it increases destruction of cells with antibody-dependent cytotoxicity. What is the side effect that sounds similar to doxorubicin, maybe, is heart cardiomyopathy. So do not use two together. Do not use the Herceptin trastuzumab with doxorubicin. He might ask this. He just keeps on repeating. So do not use together. Do not use and monitor cardiac function. If someone is HER2 positive, you do use this because it can respond, right? So you use combination of pertuzumab, another drug, trastuzumab, this one, and docetaxel, the Taxel one, in the M phase, for these types of metastatic breast cancer. Ribociclib, again targeted. So if it targets a specific inhibitor called cyclin dependent kinase 46. So cyclic, okay? It blocks the cell cycle progression because this is an important thing. It's like a kinase in the cell cycle. Side effects not major, they're the same. They are the first line with aromatase inhibitors in metastatic HR positive. So hormone receptor positive to estrogen, progesterone. It can also be given as palliative therapy. So metastatic, again, nothing to do with HER2, just hormone receptor. It improves survival. Pembrolizumab, from the name P, and it's a unique name of antibody, so it targets the checkpoint inhibitor anti-PD, PEM and PD. So anti-pembrolizumab, I cannot say the name, but it blocks the receptor and it increases immune, like, and on the immune cycle, it has an effect. So T cell activation against the tumor is done. Okay, so PD1 is yeah, PD1 is blocked. It usually stimulates the tumor cell growth, but it doesn't. So immune related effects. So by immune, I mean if they are immunosuppressed because of this, they will have infections, so colitis, pneumonitis, hepatitis, and endocrinopathies, a lot of them. So they are used in patients that do not have any receptor. You cannot target anything, so you go for immune. That's it. So used in metastatic triple negative breast cancer with chemotherapy. So you go for immune if you have triple negative, like nothing, not hormone receptor, not estrogen, not progesterone, not HER2. Okay. Last thing, hormonal based therapy. You have hormone based. So tamoxifen um is mainly like estrogen, I like to think of it. So because it's affecting the SERM. So regulate, so some places it is an antagonist at the breast, it is an agonist on some other places like the bone and the endometrium. If you remember, we talked about SERM, which was cycloclomiphene citrate in the infertility lecture. So yeah, just know that tamoxifen is just like that. It is cytostatic, more than cytocidal, and oh, sorry. Oh yeah, we're almost done. So cytostatic over cytocidal, which means it will be more static effect than killing the tumor cells. And the major side effect, because it's an and wait, sorry. I just need to charge my laptop. Give me a second. Okay, so hopefully you can still see. So sorry, I'll just go. Okay, so hormonal based tamoxifen, because it's estrogen receptor antagonist, we there will be side effect of endometrial cancer. Okay, so it's on the breast, but it's agonist on the endometrium. Sorry, so endometrial cancer can be caused because of this agonist effect. Everything estrogen related, go here. So thromboembolism, nausea, skin rash, hot flashes, vaginal discharge, because it's an antagonist, right? Um, Menstrual changes, everything, hypercalcemia with cancer. So it is used hormonal based, all hormone positive. ER positive, ER positive, ER positive, okay? Not related to HER2, not related to you can, I mean, yeah, it's not metastatic. So metastatic, you go for like more stronger. So the cyclin inhibitors. HER2 is this one. Triple negative, no hormones at all. You go for immune checkpoint. Okay. Anastrozole, which is AI aromatase inhibitor. Remember ozole aromatase, which was like letrozole. So these two are similar to that. It decreases estrogen synthesis. It can cause bone loss, fractures. That is a major side effect for aromatase inhibitor. Bone loss. So bone loss, I'm not sure how it happens, but it can cause a major effects on the bone. So you can only use it in postmenopausal ER positive cancer, and that's because again you do not want the bone loss to happen in young patients, right? Also, and fractures. So ER positive, ER positive here too. Fulvestrant is another one, selective estrogen receptor downregulator. So it degrades the estrogen receptor only without having that agonist effect. So it's pure anti-estrogenic. So this and this estrogenic, this is partly. So same effects, hot flashes, GI, used in advanced, again, okay, hormone. So 58-year-old came with this HER2 negative, receptor positive. Her by HR positive or ER positive, I mean estrogen receptor positive. If it's PR positive, it's progesterone receptor. If it's HR positive, hormone receptor, it means both estrogen and progesterone. Okay, like here, HR is hormone, so estrogen, progesterone, both. But here it's ER because it's only for estrogen. But that's why we use estrogen related drugs. Okay. Okay, so they came with this, they are using cyclophosphamide, methotrexate, fluorouracil, increasing fatigue, sore tongue, appears pale on exam, shows a macrocytic anemia. What do you think that is caused by? This is a classic picture of macrocytic anemia caused by folic acid deficiency, which is caused by fluorouracil, remember, and methotrexate both. So that is B9 deficiency. Folate is B9. What to add to this to prevent or help is the folic acid or leucovorin, folinic acid. Folinic acid, not folic acid if he asks you. Folinic acid. So someone came with stage 3 triple negative breast cancer, receiving this. She has hypertension, migraines. To mitigate this specific, okay, they added basically cyclophosphamide. Mesna was given. Which of the following adverse effect is Mesna preventing? Which one is that? Hemorrhagic cystitis, bleeding from the bladder. Remember the bladder picture. Okay, you can read this and it's basically the same thing that I explained, but you see hand-foot syndrome, palmar plantar erythrodysesthesia. So what is the mechanism of action? Firstly, what causes this? It is caused by fluorouracil 5F and U because foot, right? So that inhibits the folic acid synthesis in the first step, which is with this one, thymidinate synthetase. So that's the first step. Okay. 52-year-old, HER2 positive invasive ductal carcinoma. Basically, she has a very bad left ventricular function. Which of the following drugs is used, added to her current regimen, considering her bad echogram? And she's taking now trastuzumab, which is having an effect on the heart, right? So what do you add? Or actually, what should not be added because she's already in a bad state of the heart? You do not add to the stress, so don't add doxorubicin, the heart. Pregnant woman, 26 years, came with depression. If needed, oh, this is from the previous lecture. Which of the following antidepressants is contraindicated? We said the one with X, but OX, right? So paroxetine, because it can cause severe cardiovascular defects in the first trimester, specifically ventricular septal defect. Which of the following antibiotics contraindicated during pregnancy? Very straightforward. The one that is not gentle aminoglycosides, gentamicin. 56-year-old woman, again, back to breast cancer, reveals. Okay, so she is basically, you can read through this, but being treated for breast cancer. She was started on a drug, but now she's presenting with shortness of breath, chest pain, pleuritic chest pain. It shows pulmonary embolism, which is a thromboembolic event. Which of the following was she taking? What was the drug she was taking? I'll give you a minute. Um, what you see here is VTE, venous thromboembolism, which can be caused or increased with estrogen drugs, right? So in breast cancer, what was the estrogen, anti-estrogen drugs? We have tamoxifen and fulvestrant. In this case, I don't see the pure one, so pure anti-estrogen. So we will go with SERM. So this is what's the name of this drug? Anti-estrogenic effects, tamoxifen. Okay, don't forget tamoxifen, and that is related to this whole estrogen complication. Remember, that is what you should get out of this lecture. Hopefully, it helped. Thank you so much. If you have any questions and for feedback, this is the QR code. Please let me know at any time. Inshallah, it helps you, and best of luck.